Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's June 2019 issue. There are 5 articles that have been selected as our Editor's Choice of Highlights articles this month. Our Editor's Choice is a special article entitled The Slow Motion Catastrophe of Antimicrobial Resistance and Practical Interventions for All Prescribers. This article is authored by Dr. Emil Leshko and Mary Rose Laguia Villa from the Infectious Diseases Unit, Rochester Regional Health, Rochester, New York. All medical and surgical specialties depend on the pool of effective antibiotics that continues to evaporate because of the increasing prevalence of drug-resistant bacteria. Antimicrobial resistant infections kill 700,000 patients every year. By 2050, they are projected to cause 10 million deaths per year at a cumulative global cost of $100 trillion. Professional societies and international health agencies, including the United Nations, have declared escalating antimicrobial resistance as one of the most urgent threats to global public health and have issued calls for action. Dr. Leshko and Laguia Villa provide a compelling overview of this topic that discusses the following issues: the current and projected morbidity, mortality, and financial cost imposed by antimicrobial resistance, both nationally and globally, cellular processes in bacteria that enable resistance, the reasons for insufficient recognition by both the healthcare profession and the general public of such resistance and the threat this imposes, the causes of antimicrobial resistance, especially those originating from overdiagnosis and overtreatment with antibiotics, the diverse contributors to the phenomenon, including the increase in high-risk patient populations, certain human and societal behaviors and practices, travel, climate change, and impaired public health systems, and the scarcity of novel antibiotics in the pharmaceutical pipeline. The authors outline approaches that can mitigate antimicrobial resistance, emphasizing the fundamental importance for healthcare providers to be knowledgeable and committed participants in antimicrobial stewardship, the need to avoid unnecessary use of antibiotics, the role of limiting overdiagnosis, the need for new antibiotics, adjunctive therapies, and alternative therapies, and the importance of implementing a globally based antimicrobial stewardship. The discovery of antibiotics was an entirely serendipitous finding and one of the most important advances in modern medicine. However, addressing and limiting what occurred in the wake of this indispensable advance, the phenomenon of antimicrobial resistance, will not come about by chance. On the contrary, this will require the concerted attention and enduring dedication to antimicrobial stewardship and other strategies as so clearly outlined by Dr. Leshko and Dr. Laguia Villa. The first highlight is an original article entitled Perception of the Risk of Stroke and Risks and Benefits of Oral Anticoagulation for Stroke Prevention Among Patients with Atrial Fibrillation, a cross-sectional study. It is authored by Dr. Mohammed Hijazi and colleagues from the Division of Cardiology, West Virginia University, Morgantown, West Virginia. Stroke prevention is a cornerstone in the management of patients with atrial fibrillation. Current guidelines recommend lifelong oral anticoagulation to reduce the risk of ischemic stroke in patients with a CHA2DS2-VAS score greater than 2. However, long-term oral anticoagulation carries a significant risk of bleeding and is associated with considerable cost, lifestyle changes, and strict compliance requirements. Hence, the understanding of the patient of the role of oral anticoagulation in stroke prevention and its accompanied risks and benefits is critical. Nonetheless, several studies have demonstrated significant gaps in the knowledge of patients with atrial fibrillation regarding their condition, the treatment they are taking, and the potential alternatives despite these patients being treated for atrial fibrillation for several years. The authors conducted a cross-sectional study at a tertiary academic center to assess the patient's perception of the risks and benefits of oral anticoagulation for stroke prevention in the setting of atrial fibrillation, and compared their perceived and estimated annual risk of stroke and bleeding. Consecutive patients with chronic atrial fibrillation who presented for outpatient cardiology visits or admitted to a non-critical care cardiology ward service between September and December 2017 were invited to participate in this survey. Participants were asked to estimate their risk of stroke without oral anticoagulation and the risk of bleeding with oral anticoagulation using a quantitative risk scale. The reported values were compared with estimated risks derived from the CHADS-VAS score and the HAS-BLED score. The authors also compared the perception of patients of the stroke risk reduction afforded with oral anticoagulation compared to what is reported in the literature. A total of 227 patients were included in the analysis. Mean CHADS-VAS score was 4.3 and mean HAS-BLED score was 2.3. Atrial fibrillation was paroxysmal in 53% of patients and persistent or permanent in 47%. There was no significant correlation between the patient's perceived and estimated risk of stroke and bleeding. The majority of patients overestimated their risks of both stroke and bleeding. 53% of patients perceived an annual stroke risk greater than 20%, and 54% perceived an annual bleeding risk with oral anticoagulants greater than 10%. Most patients perceived that oral anticoagulation would reduce the annual risk of stroke by greater than 50%. The authors conclude that perceived risks of stroke and bleeding are markedly overestimated in the majority of patients with atrial fibrillation. This disparity between perceived and estimated risk is of special concern to shared decision-making and patient-centered care. Further research is needed to discern the root causes and to identify effective methods of bridging this alarming disparity. The second highlight is an original article entitled Predictors and Outcomes of Renal Replacement Therapy After Left Ventricular Assist Device Implantation. It is authored by Dr. Rabia Asley and colleagues from the Department of Cardiovascular Medicine and Cardiovascular Surgery and the Department of Health Science Research at Mayo Clinic, Rochester, Minnesota, and the Division of Cardiovascular Diseases at the University of Iowa Hospitals and Clinics, Iowa City, Iowa. Left ventricular assist devices, abbreviated LVADs, are a true innovation in the care of patients with advanced and intractable heart failure, as LVADs not only decrease patient mortality but also improve their quality of life. LVADs provide supportive care for patients awaiting heart transplantation or for the remainder of the lives of those patients for whom heart transplantation is not an option. This remarkable benefit conferred by LVADs is attended, however, by an increased risk of complications such as gastrointestinal hemorrhage and right ventricular failure. And as may occur with any intravascular mechanical device, LVADs may clot, may cause thromboembolic disease and hemolysis, or may become infected. These complicating conditions in turn can exert adverse downstream effects, including the risk of acute kidney injury. Germane to this specific complication are at least two additional considerations. First, there may be pre-existing renal impairment prior to placement of an LVAD, as congestive heart failure is commonly associated with impaired renal function, and this may predispose to renal failure following LVAD implantation. A second and offsetting consideration is that LVADs improve systemic hemodynamics and thus may be expected to ameliorate renal perfusion and function. The purpose of this study was to examine the frequency and outcomes of patients requiring renal replacement therapy, abbreviated RRT, early after LVAD implantation. The authors examined use of in-hospital RRT and outcomes in consecutive patients who underwent continuous flow LVAD implantation from February 2007 through August 2017. Logistic regression was used to examine predictions of RRT, and associations of RRT with outcomes were examined using Cox proportional hazard regression. The results demonstrated that of 354 patients who underwent LVAD implantation, 15% required in-hospital RRT. Patients receiving RRT had higher preoperative Charlson comorbidity index values, model for end-stage liver disease scores, right atrial pressure, estimated 24 urine protein levels, lower preoperative estimated glomerular filtration rate, and lower measured GFR than those who did not require RRT. Approximately 40% of patients with an eGFR less than 45 mL per minute and 24 urinary protein levels greater than 400 milligrams required RRT versus 6% with an eGFR greater than 45 mL per minute and without significant proteinuria. Lower preoperative eGFR, higher estimated 24 urinary proteinuria, higher right atrial pressure, and longer cardiopulmonary bypass time were independent predictors of RRT after LVAD implantation. Of patients requiring in-hospital RRT, 33% had renal recovery, 33% required outpatient hemodialysis, and 33% died before hospital discharge. After a median follow-up of 24 months, RRT was associated with increased risk of death and gastrointestinal bleeding with adjusted hazard ratios of 2.9 and 4.5 respectively. The authors conclude that in-hospital RRT is associated with a poor prognosis after LVAD placement. A detailed preoperative assessment of renal function before LVAD implantation may be helpful in risk stratification and patient selection. The third and fourth highlights are thematic reviews in precision medicine entitled Hereditary Cancer Syndromes, a primer under the Diagnosis and Management Part 1, Breast Ovarian Cancer Syndromes, and Hereditary Cancer Syndromes, a primer on Diagnosis and Management Part 2, Gastrointestinal Cancer Syndromes. These articles are authored by Dr. N. Jules Samada and colleagues from various divisions and departments at Mayo Clinic at all three campuses, including Scottsdale, Arizona, Jacksonville, Florida, and Rochester, Minnesota. A major aim of precision medicine is to assess the extent to which genetic determinants underlie the causation and phenotype of disease. The present and growing importance of this topic led Mayo Clinic Proceedings to dedicate a series of thematic reviews on key aspects of this field. Cancer is a disease of special attention for precision medicine, as cancer is exceeded only by cardiovascular diseases as a cause for mortality in the United States, and approximately 5 to 10% of all cancers result from a hereditary genetic defect. In the present issue of the Proceedings, Samada et al. Provide a two-part series on hereditary cancer syndromes. The first article, focused on breast ovarian cancer syndromes, discusses the relevant epidemiology, clinical manifestations, genetic testing and who should undergo such testing, and the underlying genetic defects with emphasis on the mutations in the BRCA genes. This review then proceeds to discuss breast surveillance and screening and the relative roles of risk-reducing surgery and medications. The article emphasizes a team-based approach, the essential role of a genetics clinic and counselor, and the fundamental involvement of patient support groups. An analogous approach and coverage are provided in the companion article on gastrointestinal cancer syndromes, the latter including familial adenomatous polyposis, MUTYH-associated polyposis, Lynch syndrome, and hematomatous polyposis syndromes. Both articles provide quite helpful tables that summarize key content, including indications for genetic testing and recommendations for management. The second article also highlights the diseases discussed with relevant clinical, endoscopic, radiographic, and histologic pictures. Samada et al. Thus provide an accessible, timely, important, and succinct distillation of key aspects of hereditary cancer syndromes as these apply in particular to breast, ovarian, and gastrointestinal cancers. You can access these highlights and editor's choice articles free of charge during the entire month of June. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the homepage to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on our homepage as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study. Currently, we are featuring Dr. Carlo Brugnara, a professor of pathology from Boston Children's Hospital and Harvard Medical School, Boston, Massachusetts, interviewed by our associate editor, Dr. Vincent Rajkumar. You will see many news stories at our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.